everybody. Really lovely to see you here. My name's Alison Holmes. I'm a professor in infectious diseases at Imperial College, and it's a real pleasure that we've got this afternoon here, and we've got some really, truly tremendous speakers to discuss antimicrobial resistance that really demonstrate the breadth of work that's going on at Imperial, covering a range of expertise to address this complex problem. So, welcome to you all. This is the Global Health Forum, and they hold meetings every month. And it's wonderful that this month the topic is on antimicrobial resistance, particularly because of the this is the week of worldwide antibiotic awareness. Worldwide, what was it called? World Antibiotic Awareness Week. There we are. So the timing is perfect. The other thing that we just would like to let you know about, that as well as this being a platform to bring together researchers, the public, anybody who's interested in a topic, it's also an opportunity to disseminate findings, share findings, and also that it will be followed on social media. So we need to let you know that there will be live tweeting about the event, and it's encouraged that you get involved in the conversation on Twitter. And the hashtag is IGHI, hashtag IGHI Forum. So get going on that, and you'll be very welcomed. So I think before we start, I just would like to mention that you hear an awful lot about antimicrobial resistance, and there's a huge amount on the focus of the need for new drugs. We will not be discussing the development of new drugs. We are going to be discussing the really, really important aspect of antimicrobial resistance, which is how can we use them better, and how can we improve the situation. So whilst everybody is waiting for new agents to come online, we need to do much better, and it's a complex problem. We need many aspects of research to work together to address this problem, as well as civil society. So to open up and to explain why this is such a significant issue and why we need to know all about it, we've got Damien Ming, who's going to set us the stage. Damien, over to you. Are you able to hear okay? Do you need the mic for recording? Because we do. Okay.
Hi everyone, thanks very much for having me. My name's Damien Ming. I'm an infectious diseases doctor. And as Alison says, antimicrobial resistance is a growing problem. More and more drug-resistant infections are coming on, and it's becoming harder and harder to treat them. It's a real impact in the clinic. You know, when you see people in the hospital and your GP practices, not a lot goes by without the mention of antibiotic resistance having to treat it. And I think as a clinician, what I like to do is talk you through a case and talk you through on the ground what happens when a patient presents with a possible infection, and talk about the challenges of AMR nationally and internationally. And to set the scene, this is probably what everyone imagines a hospital look like, and that's true. You know, it's quite nice, it's quite quiet. There's alcohol gel, and there's a sink washing basin there. But I think you have to be aware that most AMR and most treatment doesn't really take place in this. It takes place in very, very different contexts with different environments. And you hear about the contribution of how the environment, how the context influences AMR and what we do about it a bit later on. With that in mind, if everyone imagines with both scenarios, whether you're in the UK or away from the UK, you're seeing a patient. And this patient is 65 years old and comes with a short history of fever, back pain and vomiting. And they've got a bit of a temperature, just shy of 38, where we call a fever. And at the heart of clinical decision making, it's all about making the right decisions. It's all about doing the right things. The benefits must always outweigh the risks. Do we give treatment? Do we not give treatment? If so, what treatment do we give? And AMR is no exception. In AMR, what we need to do is give the right treatment to overcome possible drug-resistant infections. If you give the wrong treatment, it's not going to work. But at the same time, you have to be conscious that you don't give treatment that's too broad, and you want to minimize the impact of driving AMR. And I'm going to argue that the former, knowing whether you've succeeded or not, it's much easier than the latter to know how, to know what actual impact you have in the environment, and subsequent to that as well. And really, if you think about the scenario, you've got this person in front of you who says that, I'm not feeling too well. How do you actually know they've got an infection? I mean, for example, if a person has a kidney stone, you have fever, you have back pain, you have vomiting. So to know whether or not there's an infection in the first place is difficult. And we rely on this concept called clinical decision making, where we take bits of your history, your risk factors, your examination, and we all piece it all together. But there's a lot of incomplete information when we do that. And that manifests as variability in clinical decision making. So different people in different situations will get it right in different amounts of time. So there's huge variability in this clinical decision making process, this nebulous thing. But getting it right is one thing. We also have to manage risk when we treat a patient. So for example, if I think that 90% this patient does not have an infection and has a kidney stone, what do I do with the remaining 10%? Am I prepared to take the risk of that 10% of that patient having sepsis and potentially dying? Or maybe it's much easier to give antibiotics. So the risk management aspects, again, differs from place to place. What are the consequences if you miss sepsis and miss an infection? Luckily, we use a lot of tools. We've got things like blood pressure, we've got pulse, we've got biomarkers, we've got things like CRP, lactate, etc., etc. All these bits of information we need to try and integrate in our clinical decision making. But you can imagine with so many bits of data, this may well also lead to more confusion. How do we make use of all the different bits of information more effectively? And this will be covered in later talks as well, and some really exciting stuff. If we take a step back from the UK context, if we look at internationally, if, for example, you're practicing in sub-Saharan Africa, it's really hard to talk about fever or infection without talking about malaria. You either have malaria or you have something that's not malaria. And this is a big problem for malaria, obviously, but also for antimicrobial resistance. So, for example, a meta-analysis 2 years ago looked at different centers around the world where they introduced malaria testing. Now, malaria testing is pretty reliable, it's pretty quick, you get an answer within 5 minutes, but what they found is that when you introduce malaria testing to people presented with a fever, it reduced the number of inappropriate antimalarials, sure, but the antibiotic usage actually went up dramatically, 20–30%. Now, this is a complex issue, and no one really knows why this is, but you can imagine that the patient perception, the clinician perception, there's a lot to go on in there. No one really likes not having an answer. In addition, there are lots of constraints. If you're working in low-resource settings, you're very busy, there are lots of people. So the clinical decision support tools, which will be covered in later lectures, could really play a very important role in doing the right thing. So we've decided that this person probably has an infection. Well, what type of infection does he or she have? Fever, vomiting, back pain, could well be flu. Or it could be a urine infection, a virus or bacteria, one of which only responds to antibiotics. And in the UK, at the moment, what we do is we test the urine, we test, X, Y, Z. But realistically, you only get the answer within 48 hours. You need to grow the bacteria. You can't speed that up. And you only get the answer 2 days later. And for a lot of people, that's a bit too late. There's some really exciting stuff going on, molecular testing, where you detect the actual DNA of the organism directly from samples, so a swab or from urine. And this could shorten it dramatically to 1–2 hours, and this is going to be a game changer. And we'll hear about that a bit later on with Jesus. So there's a big potential impact on care. But if you remember, if you go to your GP, the GP only has actually 10 minutes, so maybe 2 hours is actually too long, and an A&E a few hours. So when we do treat infections, a lot of it is empirical. What that means is that we try and use our clinical judgment, we do a best guess antibiotic if there is an infection, but we don't actually know what the actual organism is. And this has huge implications for AMR because we could get it wrong a lot of times. If you step back a little bit more internationally, this is even trickier. In the UK, we've got good laboratory services with good chains. Patients can get their results quickly. We have good linkages. But if you're remote in the middle of nowhere in the health center, how do you get the consumables? How do you make sure the test is reliable, et cetera, et cetera? And a lot of patients travel a long way to come and see you. You know, how can you make sure that their results feed back to them and you can change the treatment appropriately? It's tricky. So I think what we all believe in this group especially is that if you could have rapid diagnostics, little boxes where you put in your samples and it gives you an answer within 1 or 2, or even handheld devices, that could be a great thing. It will directly impact on how we treat patients. We can reduce the amount of inappropriate antibiotics and really do the right thing. But of course, think back to the malaria example. We can't just put technology in and solve problems, and we need to look at the unintended consequences of introducing a new test. It's all one thing having a box that tells you what the infection is, but having the patients being satisfied with it or having the clinicians actually following what the box tells you, that's another question, and that's another one. We think this patient has a bacterial infection. How do we know what antibiotics to choose, given that a lot of infections are resistant to first-line tablet antibiotics in the UK and also internationally? This is really important. So epidemiology and surveillance to tell us what's actually happening locally. So for example, if we know that the rates of resistance to a certain antibiotic is 50% generally in the population, then we'll try not to choose that antibiotic as our first empirical choice. But again, this is dichotomy between epidemiology and clinical care. So if I know that the rate of urinary infection resistance is, say, 50%, what do I do with the individual? Do I give another antibiotic 50% of the time? So this is a dichotomy between evidence-based medicine. So you have to use epidemiology into your individual care. And I don't really have an answer to that, but surveillance is extremely important. Talking between institutions, but looking at within the institution itself, within a single hospital where the patients are similar, actually different teams think different things. So if you're an infectious disease specialist, you may think that treatment may be more appropriate compared to if you're a surgeon or if you're a pediatrician, for example. So, and this all comes down to, I think, in large part to play with the perception of risk factors, what sort of risk you're prepared to take. But this also emphasizes, this variability also emphasizes that different teams need to work together in a better way. If you look internationally, you'll find that these antibiotic guidelines, which are based on surveillance data and based on epidemiology, only really exist in well-resourced places where they're capable of knowing what sort of bugs live in the environment. 80% of all guidelines refer to developed settings. And in international, in low middle income countries where there's no up-to-date epidemiology, it makes choosing the right antibiotics even more tough. And there have been great steps in improving this, like WHO surveillance, standardizing laboratory reporting, for example, and certainly if you had rapid tests which don't rely on a big connected laboratory infrastructure, I think that could be a bridge to help build up surveillance data. Finally, you've treated an infection, you know what to take. How do we make sure that you're focusing on the individual? So if you're a patient and you've gone to your practitioner and they say it's not malaria, go home, what's to stop them from going out to the pharmacist and buying more antibiotics, for example, which is what happens in many, many countries, or self-treating? How do we know sufficiently what their worries are, provide enough reassurance, and sort of enforce the message that antibiotics should be used appropriately? That's a whole area of research. And really cool, exciting stuff, how do we make sure that when we treat an individual, so for example, if I gave you all the same antibiotics, everyone's going to react differently. You're going to have different levels of drugs. How do we make sure that the antibiotics, the important tools we have, are tailored especially to you? And we can talk a bit about some of the exciting work that we've got in terms of biosensing. I presented very discrete challenges, but don't forget, everything is interlinked. So your diagnostic links with your perception, which links with the way that you deliver care and how different teams work. And we all know that AMR has a really big health impact and economic impact, sure, but patients are dying because resistance is there and you can't treat it. And don't forget, antimicrobials really underpin a lot of medicine. So even though you can carry out surgery, if you don't have the effective antibiotics to treat the infections, you're not going to do very well. Likewise with chemotherapy, if your immune system is impaired and you don't have the antibiotics to treat the infection, then that limits the effectiveness of delivering that sort of things. AMR is an issue that really permeates throughout all of modern medicine. So hopefully in the last 10 minutes I've highlighted a few things about what it's like in a clinical setting in the context of AMR. It really represents the intersection of different issues that surround us in terms of antimicrobial resistance. And I've proposed a lot of challenges and a lot of issues, but I don't want to be pessimistic. We actually get it right quite a lot of times. People do well, but this is an ongoing challenge, and it's going to get more and more difficult as time goes by, as more resistance comes through. We're going to hear about this later on in the subsequent talks, but really innovative research, and as Alison says, making use of what we have here most efficiently as needed. So with that, thank you very much.
So thank you very much indeed, Damien. So we're going to be going from talk to talk, and then we're going to have a panel at the end and invite questions. So we've started off with a very, very clinical perspective. So at the level of the patient and managing the individual patient and the significance of AMR at the decision making and in terms of clinical management. We're now going to shift gear a little bit, and I'm going to ask John Otter to come up and change his slides whilst I give him a massive intro. So Damien touched upon this in terms of us thinking about antimicrobial resistance and the importance of selecting the right antibiotic in terms of targeting the resistance and the surveillance and the data that's needed. But it's also absolutely critical that we understand all the things that can be done to prevent us using antibiotics to begin with, to actually prevent infections and also prevent the transmission of resistance. So critically important that we understand the role of the environment and the science around addressing the environment. So over to you, John. Thank you.
Thank you, Alison. Good afternoon, everyone. Thanks for coming today. So who are you guys? Who's a student? Who's some brand of clinician? Doctors or nurses? And a fairly big group in the either abstain category, which is fine, I'm not going to force you, or other. Okay, that's really helpful, thank you. So the environment is not so much a driver of AMR, it is the all of AMR. So forget animals, forget humans, they're almost insignificant bystanders in this whole story of AMR. So it is a huge chunk of work, it is massively important, and probably the most important driver of AMR, although some of the clinicians in the room may disagree with you, or with me there. So I've got a laser pointer here, so if anybody's unruly, Anyone got any eye issues? No? Okay. So, does anybody know what this is? Have a guess. Pardon? No. I'll give you a clue. Think Fleming. It's penicillium. Very good. So, I think it's fair to say microbes are not very nice to one another. They need to try and improve their values and behaviours. Because it's all-out warfare. It's a fight for survival. The reason we have antibiotics is because of fungi. They're the ultimate source of, or the original source of antibiotics. Since then, we've created other antimicrobial agents that aren't strictly defined as antibiotics, but they're all kind of variations on a theme of a microbially derived strategy to attack, kill, inhibit, damage another microbe. So it is very much microbial warfare. So just down the way here, in a building in St Mary's, Alexander Fleming, in the 1920s, I'm sure you're well aware of the story. He left an agar plate on the bench for a bit too long and it grew some penicillium, and he noticed a little zone of inhibition on the agar in the lawn of bacteria that he had there, and he thought, oh, that's interesting, that could be something. And then he worked with other people, notably Howard Florey and Ernst Chain, to develop penicillin, the first antibiotic. And it was revolutionary. It transformed in many ways the Second World War and became a very effective therapeutic agent incredibly quickly. We've got a 1-year-old son, perforated eardrum on Monday, straight on amoxicillin. You know, within 24 hours, an improvement in symptoms, parents looking less haggard, and very good outcome. Whereas 100 years ago, okay, it may well have sorted itself out, but equally it may not. We could have a half-deaf child or a dead child. So it's really changed the way that we think about medicine. The prospect of losing that is not palatable. So I won't ask you what that is. I think you probably know. So cauliflower. So I want to use this as an illustration of the spread of antibiotic-resistant bacteria in the healthcare environment. But the healthcare environment is a very small part of the environment, and I do want to talk about the environment in the round. So some scientists in America in, I think, the late 1990s came up with a really nice novel way of investigating microbial spread in the healthcare setting. Anybody studying genetics? Good, excellent. Phew, I can get away with it. So they used a genetic type approach where they took a little bit of marker DNA from cauliflower and they inoculated a telephone receiver of a phone, and it was the 90s, so they had phones, not, you know, mobiles or pagers. It was even before pagers. A phone in the, no, that's not true actually. Pagers were around because I had one before mobile phones in 98. There you go, I'm aging myself. So they inoculated the phone, and then over the next 7 days, they looked at the spread of this cauliflower DNA across the unit. And it is phenomenal. It's published in Pediatrics in the year 2000 by Olberg et al. Have a look at the study, because within 24 hours, this marker was across the whole unit from a single point of inoculation. And you know the worst place was? The doctor's restroom. It was the most contaminated part of the whole unit, amongst other places. So it's DNA, it's a marker, it's not an organism, it's a model of transfer. And people have taken this approach and applied it in more recent times with similar findings in it, and it shows this dynamic and rapid spread between the animate and the inanimate healthcare environment, between humans, animals, if they're there, and services in healthcare. They applied for a grant to continue this work in the 90s, but it was declined on the basis of feedback from an ethics committee who were worried that the cauliflower DNA might recombine with the patient's DNA and create bad outcomes, which is utterly ridiculous and loopy, because cauliflower, which has cauliflower DNA, was allowed on the unit. So remarkable. But since then, people have picked it up and come up with some interesting outcomes. Right. I am going to stick to the times and ask for a volunteer, please. It has to be somebody I don't know. Sounds like a magic trick. It's not. Who would like to volunteer? Otherwise, I will volunteer somebody. Come on. Thank you. Mo. Did I see another hand here at the same time? Yes, come on, because I know you, or kind of. Come on down. Hi, I'm John. What's your name?
I'm Hannah.
Hi, Hannah. So, imagine you were admitted to a hospital room for some procedure or other. Would you like to have the room on the left or the room on the right?
The left.
That's the wrong answer. Why did you choose the one on the left?
Because it's not the one on the right.
Is that that's the perfect left?
Yeah.
Okay, thank you. That's all. You're done. But no, I'm not joking. You're wrong. It's the wrong answer. Because, hang on. What did you say? The room on the left? It's the right answer. Well done. You got the right answer. Because if you'd chosen the room on the right, you would have double the risk of acquiring C. difficile infection, which is an antibiotic-associated infection in hospitals. Anybody hazard a guess as to why that double risk is there?
Because everyone chooses the right way.
No, it's not due to patient choice. Yes?
Staff go from one to the other.
No, not due to staff. Who was there before? We're along the right lines. A patient with C. diff. So the room on the right, the previous occupant had C. difficile infection, whereas the room on the left, the previous occupant did not have C. difficile infection. So the room on the left, right, as you see it, is at an increased risk of acquiring that organism. Isn't that amazing? And slightly disturbing, and you start to think about choices when you enter a hospital. Questions like, well, who was in the room before me, and how was the room cleaned? And you can start making emotional arguments, like if it was my mother, which room would I want for her? Maybe less so if it was your mother-in-law. Sorry, Lois. Okay, so I want to switch gear, and I don't want to run out of time, to take us beyond the healthcare environment, because we know in a fairly controlled clinical environment, we can completely obliterate that increased risk. So if we do a good job of cleaning and disinfection by conventional, augmented, or really any method, we have the evidence now that we can take away that increased risk. So there's a really powerful argument for us investing in hospital cleaning and disinfection to make sure that we're not putting patients at unnecessary risk of acquisition of these organisms, and in doing so perpetuate the spread of antibiotic resistance. I like Damien's image of the two rooms. I think that's really relevant here. I think this picture is much more difficult in the room down here with the poor infrastructure and the rust on the bed frame than it is in here in a much newer, pristine clinical environment. Even there, it's tricky to get right. And that moves us on to the environment in the widest sense. So this is a factory by a waterway. And I just want to think briefly about antibiotics in the environment. So there's several different ways that antibiotics can find their way into the environment. And when antibiotics get into the environment, they enter that microbial war zone that we've talked about, and they don't make it better because they provide a selective pressure for resistant bacteria in the environment that eventually find their way back into human veterinary medicine and cause problems. It won't happen straight away, but it's a slow burn drip feed of an increasing reservoir of antibiotic resistance. There's a study showing that an Indian antibiotic factory pumped out 44 kilograms of ciprofloxacin, which is an antibiotic, per day. Just for comparison, 44 kilograms is what Sweden uses in a year in clinical medicine in terms of antibiotics for human health. And the concentration of ciprofloxacin in the water was higher than in a patient who's been treated with ciprofloxacin. So you can just begin to imagine the huge driver this is putting on the development and the spread of antibiotic resistance. As I said, waste is not the only way that antibiotics get into the environment, and this is some graphics from a review on AMR, which was a government funded piece of work a couple of years ago that's worth pulling out if you're interested in this. So we've got waste, we've got humans, we've got crops, livestock, agriculture, all putting antibiotics into the environment. And we certainly need to do a better job of preventing that and finding ways to stop that happening if we're going to get a handle on AMR. And it introduces the idea of sanitation. So we have antibiotic resistance all around us, more so in some parts of the world than in others. And the way to protect ourselves and society from this is improve sanitation. This is some bit of science from that report, which shows that countries with better than expected access to sanitation had high life expectancy and a lower risk of AMR. So this issue is beyond cleaning a hospital room properly. This is about access to safe water and sanitation, particularly in developing countries. And the conclusion is this idea of One Health. Has anyone heard of the idea of One Health? So it goes something like this. If we focus all of our attention on getting really, really good at diagnosing and treating antibiotic-resistant infection in developed healthcare systems, we're not going to solve this problem because the roots of that problem are so diverse and so different that we need to take a much wider view of the problem, a One Health approach, and encompass interventions, yes, in acute healthcare, but also in the community, in agriculture, in the animal kingdom generally, and in the environment, if we are going to keep a handle and reverse trends in antibiotic resistance. Thank you. So I have to dash off now, I'm really sorry. So if anyone has a question, I'd love to take it now. We've got a minute, if that's okay. Yeah, thank you.
I've got a question about measurement. So I totally agree with One
Sorry,
Health.
can you just say who you are when you ask your question as well?
Yeah, of course. So my name's Malik. I'm in infectious disease and micro-reg here at Behavioural. So, One Health, great. The question really is around how we kind of measure the impact of any particular intervention on a One Health scale. It's relatively easy to measure antimicrobial consumption in a hospital and use that as a surrogate for the impact of the intervention.
Yeah.
But when we've got this dynamic network, how can we measure that or provide some form of metric to see that we've made an improvement or made things worse?
You know, this is just off the top of my head, so it might be garbage, but it's something that I look at on a global scale is a fecal carriage rate of a resistant bacterium, for example, an ESBL producing Enterobacteriaceae species, something like that, in a healthy community person. Because we see a big range in that carriage rate from sort of 75% in the parts of the world we know have major issues with antibiotic control, right down to almost nobody in parts of the world with really good antibiotic control. So something like that, the rates of carriage of antibiotic-resistant bacteria in a healthy population could be a way to measure impact. Question here.
I'm Hannah. I do some work for a body called the Global Hygiene Council. Do you feel like national action plans are doing enough to address it in the community?
Well, in this country or elsewhere?
Kind of just
Globally.
globally.
I think if we look at this country, we're kind of uniquely separated in some ways from other parts of the world in that antibiotic control is pretty tight in this country. There's more to do, but it's pretty tight in this country, and rates of antibiotic resistance outside of acute healthcare are pretty low. So I think rightly the focus in this country has been on managing AMR mainly in acute settings, and there's been some really good success stories if we look at the trends in methicillin resistance in Staph aureus and the rate of MRSA bloodstream infections since the 90s to date. They've really gone down, and that's quite a nice success story. In terms of other parts of the world, there are some success stories, but there's also some what's the opposite of a success story? A non-success story, where some national interventions have been trialled, but the infrastructure hasn't been there to deliver them. So I think to deliver an effective community-level intervention to prevent AMR, you need to have proper governmental backing and support, and also the healthcare infrastructure to support it. Yeah.
Thomas, a paediatrician. I've been doing a lot of work in Rwanda, and there was a study there looking at fecal samples in the community,
Okay.
and it was well over 50% had resistant organisms.
Yeah.
Non-industrialized country. Where is most of that likely to come?
Yeah, it's a really good question. So we have, on a global scale, it's very much the exception rather than the rule to have good quality surveillance data on the rates of AMR. Most parts of the world, we really have no idea of what the rates are. And when you mention a study like that, it's quite common to see that. You see a study in a place where they're rarely studied and wow, you know, really high rates. I don't know the answer. It's probably to do with easy access to cheap over-the-counter antibiotics that are largely unregulated and unprescribed in the way that they're used, with cheap and counterfeit products exacerbating issues. But come back to the panel because there's more expertise there to answer that later on.
Great. Well, thank you very much indeed, John. So as John said, this is a wider problem. It's not just the bug, it's not just the environment, it's not just the patient. Really, really importantly, we need to consider not just technologies, but we need to consider behaviours. So we're going to shift gear a little bit now to something that's incredibly important, and also to recognise that whilst we're at Imperial, which is largely technological, we have an extraordinary amount of research that's around the social sciences and behaviours around improving how we use antimicrobials. And Enrique Castro-Sanchez, my colleague here, is a real expert in this, and we're delighted he can talk to us today. Enrique.
Thank you, Alison. Thank you for the opportunity to be here, talking about behavior change and the workforce and infection prevention and AMR. So it's a whole package, isn't it? It's not just one health. It's one combined approach, I would say. I think it's a fantastic time to be working in infection prevention and AMS. You know, we do have some problems, but that makes it really exciting, really challenging, and keep us on our toes. And some of the examples of this progress that we're experiencing is these core competencies across the European Union, focus on infection prevention and control, as well as AMS. And not only we've got these documents, but they're harmonized documents. So across the European Union, healthcare workers are kind of expected to know, behave and practice in a sort of homogeneous way. And I think that responds to the global challenge of AMS and IPC. However, IPC and AMS or AMR are not a linear process, and as humans are messy, so is the process. In my opinion, technical solutions to the challenge presented by infection prevention and drug-resistant infections are not enough. And what do I mean by technical solutions? For example, education. So when we've looked at the education provided to all the healthcare and animal health professionals across the UK, asking all the universities around the country, or in the 4 countries, what were they actually teaching to the students in terms of appropriate use of antibiotic, not pharmacology, not microbiology, not therapeutics, but what were they teaching them about? You can see that some professions, you know, dentistry and medicine, had quite a little bit of education about appropriate use of antibiotic, but other professions such as nurses or vets, and the bottom 2 lines, had much less content and not all the appropriate content. And that's important because that has allowed us to try to resolve that gap. So we've thought about the need to have systemic education approaches, and in collaboration with Health Education England, for example, now all the nurses in the country have got a remit to be not only aware about antimicrobial resistance, but also to act as antimicrobial stewards. So I think that's been a success story from the work that we've conducted. But of course, it's not just about knowing about infection prevention. It's not just about knowing about antimicrobial resistance. I think it's important that we have a focus on competencies, so people know what they need to do and how they need to behave. And we've been quite successful, I think, in the unit, developing competencies for all healthcare workers. So not only we're developing the content, but we're developing the skills and the behaviors that people should have. And if you're thinking about what kind of model should you have in your country or your setting related to, in this particular case, nurses, we have also developed those models of service delivery. So you can see that we're moving on from education at the individual level to kind of the assistance focus on what kind of workers we should have when we want to address the challenge of AMR and IPC. And we have also been really fortunate to link up with WHO, and today, for example, it was the launch of some competency frameworks for workers in low and middle income countries. So again, you can see how we have got this global vision and this global scale. Now the problem, and apologies, because that should say more education does not mean more confidence among prescribers. we've got plenty of evidence that prescribers tell us, you're giving me more education and training, but I don't feel more equipped to deal with prescriptions and infections and that uncertainty that Damien was referring to before. So you may also think about using guidelines to try to address those gaps, but you know, as you know, if you've got neighbours like my neighbours in Barcelona, you know, they will transform reality to a point that it would be quite different to what actually happens. So people will use guidelines in a way that probably wasn't intended to be used in that way. And of course, humans are fantastically adept at getting bored. You know, the engagement with any solution will decay with time. So we need to think about ways of keeping people interested and engaged. And this is just an example of the lack of engagement with interventions. So, you know, we introduce an intervention, humans get engaged, they love novelty, things improve, and as soon as we stop the intervention, shortly after, we go back to as we were. I suppose you knew already all these, that's why you're here, you've got some interest, you're clinicians. You may have not one of these ones, but something very similar to these, isn't it? You've got one of these. It was fascinating, I was reading the other day that the earpods that you can buy now for a couple of £100 has got more computing power than the computer that took us to the moon 50 years ago. It's quite freaky, isn't it? Anyway, when we've developed technology-based solutions, they have had an impact not only on the prescribing knowledge or the knowledge of prescribers about AMR, but also more interestingly, they reported feeling influenced to prescribe in a different way. So we've exploited that influence and that behavioural component of technology-based solutions. So we have developed some patient safety or technology-based patient safety tools. So this is an app so people can see videos about how to wash their hands, and they can listen to podcasts and download information. So, you know, moving away from what we currently offer, which is boring and not tailored information solutions, to something a little bit more modern, a little bit more dynamic. And that way we can also learn, and this is what I'm interested about, we can learn about what is of interest to people. We can see how they curate information of their interest. So the app will tell us what people are picking up from different places related to infection. So then we can see whether that information is of quality and we can develop interventions. But again, even if you're thinking about technology-based solutions, humans will get bored and they will stop engaging with it. But it may be that we've got another solution. It may be that, you know, if we appeal to the emotional side of experiences, you know, emotions really make experiences stick in our brain, and experiences is not just the lived experience, but the knowledge that goes with that experience, and that's thank you to that wonderful natural drug dopamine. I also propose that playing is something universal. Every culture ever, every human group ever enjoyed playing and playing together. So maybe if we combine all those emotional ingredients with a little bit of collaboration with technology and competition, that we have got this games health concept, isn't it? And games health and games and gamification, I mean, although they are quite new, applied to infection prevention and AMS, they're not really new in terms of health. So, you know, already some colleagues a few years ago predicted that gamification will become increasingly familiar in healthcare. You may be thinking, I haven't seen any gamification stuff, Enrique. I don't really know what you're talking about. I don't see that. Have you got something like that? You got one of those? One of these? The TripAdvisor thing, or Uber, or something like that. So all the psychological cues and techniques that are within gamification are within these platforms. So you got points appealing to your mastery and your sense of competition. You got your personalized platform. You've got some badges, and you've got this sort of counting and scoring, isn't it? All those are there simply to keep you hooked on the platform. So maybe we can use that and keep people using our platforms and solutions. And by the way, we're not the only ones using gamification. WHO has developed games and is using gamification focused on IPC and AMS. So we have developed our, I don't know whether you want to call it a game or a virtual simulated prescribing platform, and that sounds much more scientific. But we have developed a game together with expert companies that essentially try to teach you what the right behaviors are. We're not interested in teaching you what's the right drug to treat the whatever bug. These are the prescribing behaviors, which is the nationally agreed prescribing behaviors. And we have to create some personae, some archetypes about behaviors. So, for example, here we thought that doctors will want to cure people as soon as possible, even if it meant being quite aggressive and forthcoming with their prescribing. And patients wanted to feel better quickly, even if it meant being treated with really aggressive and potent antimicrobials. So this is the game that you can download and you can use, and it looks like that because people wanted it to look like that. So it was co-produced and co-designed with users. You got your symptoms that appear, and then as in real life, you really need to make a decision, and maybe that if you make that decision too soon, well, your patient will die, so your score will be quite poor. And if you're too lazy or too slow making that decision, then your patient will also die. But it's important to realize what this tool offers. It offers us the possibility of giving people immediate feedback about their performance, which is an evidence-based behavior to improve such performance. We cannot really do that in real life, isn't it? The academic detailing, the telling people how they did, takes some time, whereas the game does that immediately. And not only from the point of view of the clinical decision making, but for the point of view of your impact on other healthcare workers and other members of the team. So again, we cannot do that in real life. And we appeal to all those game elements. You know, you have to deal with lots of cases of increased urgency. We can see what makes you change your behavior more efficiently. So as a doctor, for example, will you change your behavior more promptly if patients tell you that your performance is poor? Or if the government, the CQC, tells you that your performance is poor? Or if nurses or your peers? And again, this is a wonderful opportunity to do ABC studies, isn't it? What is it more efficient to change your behavior? That's extremely difficult to do in real life. As I say, you get immediate feedback, and we track players, and we've been quite lucky that it has attracted international interest, this teaching platform. And we have also reflected upon the challenges of introducing a technology-based solution. So it's not just about developing a tool, particularly a game that may have connotations. Will people want to be seen playing a game when they are in a clinical setting? So we have done some work with potential users and commissioners to see how people will find it most useful to implement in real practice. And just summing up and finishing, I suppose that a natural extension of that gaming tool is benefiting from some of the more powerful and innovative platforms that are coming, like virtual reality. And this is the Ebola training platform that MSF used or uses to train people to don the personal protection equipment. So we thought, hang on, it's been used in practice. So in collaboration with Coventry University, this is a very early prototype that aims to train doctors or prescribers to deal with patients asking for antibiotics, which apparently is one of the reasons why doctors or prescribers feel compelled to prescribe when they even know that that may not be the best therapeutic option. But people feel stressed and anxious, they feel compelled. So this training, this simulator, puts prescribers in that situation, and with an Apple Watch we can sort of monitor the heart rate so that we can see the point at which people are getting stressed. It's a bit like mindfulness. You know, we try to recognize the symptoms of the signs of that stress and kind of deal with it. So this is an early prototype, and together with the colleagues in Germany and France, we have got a European funded project that wants to train behaviors in the surgical operating theatre, in the operating room, because it's a difficult place to gain skills and gain experience about how to move and where to move to. So this is another platform that students, medical students, will be trained. They can put these goggles, virtual reality goggles, and they can then move around virtually and see. You may be thinking, that's really expensive, Enrique, that's not going to work in my... In Rwanda, for example, well, you can get headsets for £50, which is not a small amount, but we can also get headsets for £3, the Google Cardboard, okay? And everything works as well as it would work in London. So I propose that, and that's Euphrasie, that's a nurse from Rwanda that I went to visit, and I'm always so grateful. But it may be that this platform can be quite rapidly scaled and implement it in settings where this kind of training may be quite useful. So to sum up, of course, thank you for your time and attention, and I propose that whilst technology-based interventions can improve behaviours and knowledge, we cannot forget that they could have unintended consequences and opportunity cost, but there are wonderful opportunities that are worth exploring. Thank you.
So thank you so much, Enrique. So I think that's really rather elegant. It's actually looking at technology and how we can use technology to improve behaviours. So really bringing technology, behaviour and social science all together to see if we can improve both infection prevention behaviours and antimicrobial prescribing behaviours. So I think that's a really, really lovely coordinated approach to this issue. So Enrique mentioned training in surgery. John touched upon what goes on in surgery. Damien also mentioned the importance of addressing antimicrobial resistance and what it means for surgery. And this is so important globally in terms of surgical outcomes. And as Nita Chirani is going to talk to us a little bit more. So over to you, Nita.
Thank you very much, and it's a pleasure to be here and have such a engaged audience at such a cold date who've come all this way to listen to us. So I've been tasked to talk about global surgical outcomes, patient pathways, local context and AMR. And so I'm a pharmacist by background, and I used to work as an antimicrobial pharmacist for 10 years before I came into research. And what motivated me to conduct the research I do is because throughout my career I've noticed how much contextual differences can impact outcomes. This is an extreme example, but for example, as a pharmacist I'm interested in drug charts. So this is examples of medication charts from different parts of the world. This is an ad hoc drug chart in Gulu Hospital in Uganda, where because paper charts are so expensive, people have to, prescribers literally use exercise books and make up their own medication charts. This is a prescription chart from our hospital in India where we work, where they've tried innovation by highlighting the antibiotic chart as separate from the rest of the medications because they kept getting missed and antibiotics were getting missed. And that's the very state-of-the-art prescription chart specifically for antibiotics in UCT, University of Cape Town in South Africa, and they've published. And this is how medications in most of our African countries are given out to patients in plastic bags with just the right number of drugs to be used. And we want to implement antibiotic stewardship and implement interventions to improve prescribing across all these different settings with these different resources. And this is just one example of different contextual differences. I could put up similar examples about laboratories and how different they are, about infection prevention and control procedures, and we saw in Dr. Ming and Dr. Otter's talks, there are contextual differences across the board. So for us, the work that we do is trying to understand how can we develop interventions that are sustainable in the long term by addressing the contextual differences in different settings. And we started our research by trying to understand why physicians prescribe the way they do in hospitals. Despite policy and guidelines being available, for many years, evidence-based guidelines have been made available to clinicians. We are still not getting antibiotic prescribing right in hospitals. And the reason why we focus in hospitals is because that's most of the systemic intravenous and broad-spectrum antibiotics are still used in hospitals, and we treat sicker patients and we keep them alive for longer using invasive therapies in hospitals. So the risk of transmission of infection and emergence of antimicrobial resistance remains high in hospitals, and that's why we focus our research there. And we began by looking at the existing evidence in the literature, and we found that despite a lot of interventions being published around what works and what doesn't work in changing prescribing behaviours in hospitals, there was very little information about why people chose specific interventions in different settings and whether any thought had been given to what would actually work in this particular hospital and amongst this particular group of individuals. So we went back to Imperial and we interviewed healthcare professionals who we identify as having a role in making decisions around infections, and this includes nurses. As Enrique highlighted, nurses play a key role in medication administration, review, and looking after the patients whilst they're in hospital. We also included pharmacists and we included doctors. Now, we work in an environment in the UK where it is very multidisciplinary around antibiotic stewardship. The rest of the world still lags behind in this, and it's primarily doctors who have a role to play. But so we interviewed these individuals and we discussed with them about what motivates their decision making around infection management and antibiotic prescribing, and we described a set of unwritten rules that seem to be trumping policy and guidelines that we provide for our healthcare professionals. And these rules included an acceptance of non-compliance to policy by senior physicians, a reluctance to change the prescribing of colleagues even where physicians thought it was inappropriate, because they want to give they respect the clinical autonomy of their peers and colleagues. And so these social norms and social rituals are actually having an impact on patient outcomes, and we see this time and time again in hospitals. The other thing to highlight is that up until then there hadn't been much social science research, interviewing people, observing how people practice in their natural environment to try and understand the contextual influences. A lot of the data was focused on very quantitative, statistically powered studies, and it was a first for us to be able to get qualitative research published in high-ranking, respectable medical journals, and to highlight that we need to do studies like this to understand how we can develop better, more sustainable interventions. Coming back to what Professor Holmes was saying about the global burden in relation to infections, and particularly in relation to surgery, we conducted a study across 5 different countries: Norway, France, England, Burkina Faso and India, targeting hospitals that had established stewardship programs successfully, because we wanted to learn from how these organizations were able to implement stewardship in different healthcare environments with different resources. And if we were to plot this graph for any infection, this happens to be about the reported resistance to a very common bug, E. coli in the urine, versus the number of hospital beds per 1,000 population, that's the bubble size, and expenditure per capita, expenditure on healthcare per capita. And if we use any infection market, this is the pattern you get. The burden of infectious diseases is highest where the resources are the lowest. And so that's something that we need to consider. And antimicrobial resistance is a global issue, so it isn't enough to address it in the UK. We have to look at it from a global context. And when we spoke to these individuals in these very different healthcare settings with different resource limitations, all of them told us that the most difficult specialty to engage with was a surgical specialty in antimicrobial stewardship. And this is important because if you look at the literature, and we've conducted 3 Cochrane systematic reviews looking at antibiotic interventions in hospitals. The majority of the interventions target junior doctors, and the majority of these interventions target the medical specialty because we consider them to be the easy to go to specialty. So we've actually neglected the surgical specialty in the long term in antibiotic stewardship. So we came back to Imperial and decided to do an in-depth ethnographic study of observing clinical practice across medical and surgical specialties here at St. Mary's. We're choosing this site because it is our busiest hospital site. And we specifically were looking for the cultural determinants of behavior. We were trying to understand how do people integrate and interact and communicate with each other as members of a team? How do they integrate with other members across different specialties? And what tools do they use to make decisions? How much is policy and guidelines informing practice? And we were able to describe, through qualitative interviews, through observations, and also collecting quantitative data on patient outcomes, we were able to describe how the differences that are more along the cultural and social norms within specialties, how they can have an impact on prescribing outcomes. Again, we were able to publish our work in medical journals that recognize the necessity to conduct such studies in looking at behaviors around antibiotic prescribing. And what we were able to describe was that, particularly in the surgical specialty, antibiotic decision-making remains peripheral to the central objective and priorities of the surgical teams. I don't know if there is anyone from surgery here, whether you agree or disagree with me, but what we have found is that within the surgical specialty, infections are an unwanted outcome. It is unacceptable for a patient to have a negative outcome in surgery, much more so than in medicine. Death is an accepted outcome in medical cohort patients because patients are frail, they have multi-morbid disease, there are many reasons why a patient may die whilst they're being looked after under the medical specialty. In the surgical specialty, if a patient dies or comes to harm, it is a case of extreme scrutiny, and the surgeons have to defend what they did to cause harm to the patient. And that harm includes surgical site infections, antibiotic resistance and infections. So the surgeons behave much more defensively and often prescribe antibiotics to prevent an infection rather than to treat one that has clinical evidence. And also we identified that within the surgical specialties, there was much more willingness to delegate the responsibility for antibiotic prescribing to other team members from other specialties if they felt they could trust them, if they were another consultant from another team. So we need to utilize this knowledge and work with the surgical teams to develop better interventions that takes into account how the surgeons evaluate risk in relation to antibiotic prescribing. So we also try to map all the opportunities for transmission of infection along the surgical pathway, and therefore all the opportunities for improving practice. And what we found is that when we compare this with the literature, most of the literature still from the surgical specialty focuses on preventing a surgical site infection, that's an infection that occurs on the surgical wound post-operatively, or to optimize the antibiotics that are given to patients before surgery to prevent an infection. There is very, very little evidence about what happens to a patient whilst they're on the ward recovering post-operatively from an infection, because surgical patients are at as high, if not greater risk of acquiring infections post-operatively because of the invasive devices that are used to treat them. So just quickly to come back, so that was the qualitative study. We also collected quantitative data on the cohort of patients we followed, and both in medicine and surgery, and we were able to describe that on the whole, in the study population we had, the surgical patients were much more likely to be prescribed antibiotics for longer, more likely for it to be intravenous, and much more likely for the antibiotic prescribed to not be appropriate, not be according to policy and guidelines. And because of all these reasons, we think that we need to spend more time observing improving antibiotic use in the surgical specialty. That was a study in the UK, in one little hospital here at Imperial. What does it mean in the rest of the world? When we look at the evidence from antibiotic use in hospitals, the majority of the evidence comes from the North American countries and Europe. There's very little evidence from the rest of the world in terms of what works in different settings. So what we're trying to do now is extend the methodologies we use in our study at Imperial, and we were very fortunate to get funding from the Economic and Social Research Council to tackle antimicrobial resistance in different healthcare settings and economies, and we are collaborating with colleagues in Amritsar University in Kerala and University of Cape Town and Butare in Rwanda to be able to extend our study across different surgical specialties in these different healthcare settings to understand how we can improve outcomes. We have an extremely multidisciplinary team of experts, including health system level and policy expertise, modeling, social science research, but also implementation research to be able to use the evidence we're collecting about the factors that influence decision making in different settings and develop interventions that are bespoke and specific to those settings. We're also very keen on capacity building, and we have a team of researchers in both countries representing nursing, pharmacy, implementation science, and really these researchers who are fantastic are leading the research. We're kind of stepping back and letting them own the work locally. And what is very important to us is patient involvement in the study, because although we were not able in the UK study to include patients, we didn't have ethical approval. In South Africa and India we do, and we're getting really invaluable data about how poor we are in communicating the care that patients receive in hospital with them, and how poor we are at communicating with patients at a level that they understand and are able to make decisions based on the information we give them. And we have a fantastic patient representative from South Africa, Vanessa Carter, who's a very important member of our International Advisory Board, and she herself went through a very traumatic car traffic accident and developed MRSA in her face. So she has a very personal story about how antimicrobial resistance has affected her life. But what is important to us in this study is we're going to use this knowledge that we're gaining from patients to make sure we include the patients in the interventions that we develop, to be able to make sure that we also have an impact on decision making by patients in terms of antibiotic use. So very briefly, just to summarize what we are trying to do in this study is we're trying to map the processes across the surgical pathway from the home and outpatient setting right the way through to intensive care operating theatres to outpatient setting, to understand what the gaps are within the pathway in terms of antibiotic use and infection management, and how we can develop interventions that are that address these gaps. For example, what we have identified is, of all these stages in patient care, the most multidisciplinary stage is in the ICU unit, where the teams actually from pharmacy, nursing, surgery, anaesthetists, they all come together and are able to deliberate decisions that are effective for the patient. As soon as the patient leaves the ICU, we see a lot of gaps in decision making, which is because of the disjointed communication between teams. We're also conducting case studies of individual patients across the surgical pathway, and this is just an illustration of the number of interventions that a patient undergoes who has come for surgery. So this was a patient who had come for surgery in India, and just for the 42 days she was in hospital, she was looked after by 39 different members of staff who had a role in her care that was related to her infection. And also we're trying to track the number of tests that are done for patients and the sheer number of days that the patient in green you can see stays on antibiotics, often broad spectrum antibiotics. Some of them are necessary. So there is a lot that we can learn from tracking patients and their experience through the pathway. The other thing that we're trying to do, as I mentioned earlier, most antibiotic prescribing or stewardship interventions focus on junior doctors. And what we're trying to map is identify all the different healthcare professional groups and individuals who have a role at the different stages of decision making for antibiotic use and infection control, from prescribing the antibiotics to prevent an infection through to actively treating infections, and also looking after the patient in the hospital wards to make sure that they don't get infections. So there are so many different people involved at different stages. And really, if we are going to develop sustainable interventions, we need to identify this and work with this. I just want to finish by saying that all the methodologies that I've described and our studies have been put together as a free open online course, which you can access, and it was actually launched this week. I can send a link around through later, but feel free to have a look. It's quite interesting. And we have examples of antibiotic stewardship from Uganda, India, South Africa, and UK from experts in each of the countries. Thank you.
So thank you very much, Asita. Maybe just leave the slide up just for a
Yeah.
second of the massive online learning course. So thank you very much indeed, Esmita. So really critically important that when we think about antimicrobial resistance globally, we're not just thinking about the development of new antimicrobials, new targets, but we're thinking about behaviours. However, one of the really important aspects of changing behaviour, as Damien Ming said at the beginning, in terms of trying to improve how we use antibiotics and target them, is about how we use diagnostics. So, Jesus, could you come up and change your slides whilst I introduce you a little bit further? I think it's really incredibly rich, the work we have in terms of multidisciplinary working. So we can go from looking at antimicrobial resistance from a social science and behavioural perspective, a clinical perspective, a diagnostic and technological perspective, and with such extraordinary expertise. And whilst most of our work is addressing issues within our country and with our own National Health Service, we also are truly trying to make things relevant in the world context, and particularly in lower middle income countries. And there's some beautiful work going on in diagnostics that Jesus will be able to tell us about. Jesus.
Hello everyone, thank you very much for being here today. So in the next 10 minutes I'm going to be talking about the need for innovation in diagnostics for CPE. So you're going to be focused on CPE, everything I'm going to be talking about. And I'm going to present new methodology that I think is going to be essential to actually improve surveillance and screening of CPE. So what's CPE? CPE, or carbapenemase producing Enterobacteriaceae, is a family of bacteria, gram-negative bacteria, which is becoming resistant to nearly all available antibiotics. So it represents a huge global threat and a huge burden for healthcare systems, particularly for NHS. The problem with CPE is that it's a multifactorial problem. It involves multiple bacterial species like Klebsiella, E. coli, Enterobacter, and hundreds of different variants. So as you can imagine, this is really difficult to tackle from a diagnostic point of view. So as you can see in this plot here, was published in 2018 by Public Health England. So the number of variants and resistant mechanisms and the number of cases over time is dramatically increasing. So despite improvement in sanitation and medicine, no, we still have an increased rate of CPE. So this is a problem really important and we need to tackle as soon as possible. So in this table here, I try to summarize all the different methods for CPE that are currently available in healthcare systems. On top of the table, you have classical microbiological methods, such as broth, cultures, mix, and also rapid tests. All of them are really affordable, really cheap, and they don't need specialized equipment. But unfortunately, they either take, or they really have moderate accuracy, or they take too long in order to provide a diagnostic. And then on the bottom of the table, we have more sophisticated diagnostic systems, like whole genome sequencing, MALDI-TOF, or nucleic acid amplifications, microarray, which are really good in terms of accuracy, and some of them also have really quick turnaround, but unfortunately, they are really expensive. So my personal interest is in nucleic acid amplification methods, because I think they combine the features that will make actually possible to deliver this perfect diagnostic. I'm going to be talking about that today. So just as an example of the problem it represents to have such a variability of methods and not having this ideal perfect diagnostic. So this is how the current diagnostic screening algorithm looks for one of our partner hospitals within the Imperial NHS Trust. So this, as you can see, this is way too complex and way too many steps and way too expensive. So although in average I would say 24, 72 hours is a good time to get diagnostics you can get from this, but in some cases you can have up to 2 weeks. So we need new diagnostic solutions. So what's the problem about detecting CPE using nucleic acids? So as I said, too many targets, it's too complex, so which make it too expensive. So there are currently 2 different ways to try to approach this problem. You can run multiple reactions in parallel, so try to have as many ways as possible to try to combine all the different combinations, which have 2 main problems: a lot of consumables, really expensive, or really complex instruments. And then the other option is to use a multiplexing approach, which means basically to combine different assays for our different targets in one reaction, minimizing the amount of reagents and wells. The problem with that, if you want to differentiate the different reactions in one single tube, you need to use fluorescent probes, which are really expensive, or you need to do post-PCR processes, like agarose gels, melting curve, or sequencing, which increase the time and turnaround time. So price and turnaround time. So there is not a perfect solution. There are available solutions in the market already established in the hospitals, like the ones I presented here, different instruments, methods, and actually there is also new efforts in research that are trying to bring this and diagnostics outside of the lab, as Leiswood platform that Pantelis will be talking in the next talk. And all of these methods that are nucleic acid based, they share in common, they all amplify DNA and they all use fluorescence. So how does it work today? So you get a sample of your unknown DNA, and then if it's positive, you start amplifying the DNA, you start increasing the amount of DNA, and then you get a signal in your instrument. So that would be typical reaction from a PCR. You are familiar with it. So it is normally a sigmoidal curve. And what we do today with that information is really simple. So we just set up a threshold and we determine a time to positive. So if the amplification plot cross our threshold, we say it's positive. That's all. There are different methods that are CT, the common one. You have CY, F0, which are alternatives to the CT method to try to compensate for different efficiency problems of the reaction. But in summary, we all do the same. Single point, positive. So if you want to do something else, then what we do, we basically build up standard curves, which consist of you run non-concentration of DNA, you determine your CT, and then you have a linear regression between the two parameters that you can use to estimate the concentration of the sample. So you get your sample, you say the CT, okay, my sample is CT 15, concentration 10 to the 6, 10 to the 7, okay? So today, 2019, we have here actually a lot of information contained in this amplification curve. You actually have, in this case, 21 data points, or it can be more, it can be 100 data points. So the amplification curve is the result of the kinetics of the amplification. So every amplification curve is a specific of the parameter you're using, is a specific of the sequence that it's amplified, presence of SNPs. So we are not using any of this information. We just say single point, that's all. So what we have done, we have developed a method that tries to increase the capabilities of existing instruments. So we basically, by using machine learning and conventional and clustering algorithms, we try to maximize the output of existing instruments already in the NHS, already in the system. So we don't need to modify anything. We just do data analytics to get more information. This is, by the way, patent pending. I don't know if you care, but so the way we do it is really simple, and I think that's the magic of the methodology. So as I said, you get an amplification or your reaction with a multiplex assay. You get a sigmoidal curve, and then as in this example, I'm using just 3 parameters to make it easy. You get the 3 parameters, and you combine them in what we call the feature space, in a multidimensional space. So by doing that, we can generate 3-dimensional patterns, okay, that we can use to generate kinetic signatures. Okay, it sounds really fancy, but it's basically with the coupled information contained in the amplification curve to try to cluster it in the 3-dimensional space. So in such a way that when we have a positive, we can tell, okay, it's positive, because it crosses our thresholds. The faster the reaction, the higher the concentration, but also without using any post-PCR or any kind of labeling, we can cluster and we can say, okay, this is a positive coming from BIM. Does it make sense? Yes? So just a bit of more in detail what we do. So this is we call it multidimensional standard curve. So we run the same way as we did with the conventional standards. We generate 3-dimensional cluster that actually is linear as well in the 3D space. And if we do a orthogonal view of this standard, we can generate, a cluster, right? This is basically the space we are looking at here. So we can we can use the distance as a probability measure. So we can basically define how probable is my cluster to belong to my target of interest. So by doing that, we can detect outliers. By doing that, we can actually achieve single channel multiplexing without any post-PCR. So we have demonstrated we can multiplex in a single reaction, one channel, not post-processing, the 4 of the most important CPE genes. And we have used that to validate or to sort some samples. So next steps for that, we want to investigate the presence of combined positive, like mixed signatures, when you have multiple genes in the same reaction. We want to expand the number of targets, so we did 10, but we want to increase it to 10 or as much as possible. We are running a validation assay or investigation at Charing Cross. Oh yeah, we try to integrate actually this methodology within the microbiology lab, try to get directly samples and see if we can implement that and we can decrease the price and the time. And we can investigate this methodology for other different resistances. So and then finally, so thanks to the CBIT group at Department of Electrical Engineering, led by Pantelis Giorgio, and the CP working group in medicine, led by Alison, and of course the funders. Thank you very much.
So thank you very much, Jesus. So that was really important for those of you who feel a little bit uncomfortable when we talk about social sciences. So I hope that kind of made you feel a bit more techy and comfortable and that you're back at Imperial. So I think that's truly elegant. So it's also applying some incredible thinking to existing technology that we use already. So applying machine learning, artificial intelligence to how we already look at antimicrobial resistance and diagnostics tests. But now we're going to move on to how we can look at artificial intelligence in a more broader platform and how we can use it to aid decision making. So my dear colleague, Pantelis, is going to educate us about this. And I think this also demonstrates some really nice working between bioengineering and medicine and infection prevention and antimicrobial stewardship. So really, really nice work. So Pantelis, thank you.
Thank you very much, Alison. There we go. So thank you very much for giving me the opportunity to give this talk. Just a disclaimer, I'm not a medic, I'm an engineer, and hopefully throughout the next 10 minutes I'm going to convince you how basically technology, through the application of machine learning and microchip technology for diagnostics, can impact in antimicrobial resistance. And as I said, I come from a background in engineering, not in medicine. I've spent a lot of my life designing these little things. They're called microchips. They're sitting in every single laptop that I see open here, and all your mobile phones, because it's powering them. But I'm going to show you how we're actually using these microchips to detect basically bacteria, and specifically resistant genes in bacteria, to actually guide how you prescribe antibiotics. But before I introduce that, I'm going to also show you some work that we've done in collaboration with Alison and the Health Protection Research Unit in creating decision support systems. These are AI-based systems which provide support to prescribing clinicians, and with the opportunity to link into electronic health records, we're able, with some fairly good accuracy, predict, for example, the onsets of infection, but also make a good guess as to what the right antibiotic is to use. So I'm going to start off with the first platform we developed. It's called EpiKimPOC, great collaboration of many minds combining medicine and engineering. It was funded by the IGHI, and what our ambition was to create basically a tablet-based system that you could use at the bedside. It would link into electronic health records and answer the question, what antibiotic should I prescribe? And that's basically using what's called a decision support system. I mean, decision support systems are great tools. I mean, they've been shown that they can improve the appropriateness of antimicrobial prescribing, because it can guide, for example, junior practicing clinicians as to what the right antibiotic to use. And with the right antibiotic, you can improve patient outcomes. You can also reduce costs, because you're not starting with something which is very broad, and then you'll need to rapidly change it and increase the length of stay in hospital. And also through interaction with these types of technology, as we saw from Enrique, you can also promote changes in behavior. So what we did was we created an AI-based platform. It's quite a modular platform, contained a number of modules, which we developed based on the work that Tim Rawson did, where he actually mapped the decision-making process when somebody prescribes antibiotics. We were quite fortunate to work with Imperial College NHS Trust, the ICT group, and we actually linked our system straight into Cerner, so we could pull out electronic health records and get real-time data from pathology, microbiology, but also admin, linking up to 100,000 patients. And we could output the results on a web-based platform, which was modular. It could work on any smartphone, any tablet, any laptop. As you can see here, the platform's quite modular, and what I mean by modular is that we've developed individual modules to serve specific purposes. what the modules have is one that can predict infection based on routine biomarkers using machine learning. So it becomes a classification problem. We've got one which suggests what the right antibiotic is for the given case, and that uses an AI-based technique called case-based reasoning, which is quite a simple yet powerful tool in that it actually replicates the thinking process of a clinician. So when a clinician sees a case which presents itself, he recollects from memory and experience what the right antibiotic is to use. In a similar fashion, case-based reasoning looks up a database of stored cases of previous infections, and we're able to profile the patients and look for similar cases. And then based on the similar case, it suggests similar historical cases similar to the one that you're seeing at the bedside, and it suggests which antibiotics were used, which ones worked and which didn't work. And that helps the clinician then make a judgment call as to which antibiotic to use. We're also looking at antibiotic precision dosing, where we're using closed loop algorithms to basically optimize antimicrobial therapy. And that's in response to how much antibiotic should you give. You know, it's not a one shoe fits all. We've also developed visualization tools, you know, using some advanced software packages, which, you know, gives you some nice visuals so that you can quickly respond and make a decision. So here you can see on the x-axis is a list of antibiotics, and on the y-axis is the organisms, and the flashing lights of which ones. Green is good, basically it works. Red is bad, it doesn't work. And, you know, we've also got lots of data and demographics, so we can make lots of time series analysis to actually improve outcomes. But also we can influence patient behaviours, so we've also included the patient engagement module as well, which is a little vignette which tells the patient the outcome and helps him change his behaviours. So because of the interest of time, I'm going to focus on two things. So basically the decision support system using CBR, and this is our user interface. This is a web-based platform, so it's very versatile. We've actually CE-marked this now, so it's ready to deploy within the NHS. And it presents you with a variety of information which is relevant to make you prescribe, basically give you the most information that you need to prescribe the right antibiotic. And what you see here, after the case-based reasoning is run, it brings up the cases. You can see there, you can't see the colour, but clearly it's green basically, which says these were the similar cases that presented in the past, and it gives you which antibiotics were used. And we actually ran this in a small trial on general critical care and general care, and we found that 93% of the time the algorithm came up with the same choice as a prescribing clinician, which was great. But also it saved about 40 minutes of time per microbiology round, which was huge saves in. So there's lots of potential benefits and also financial benefits. Moving on, using the techniques of machine learning, where if you're given some data, you can predict something. We came up with basically 6 routine markers which are generally measured on admission to hospital, and we asked the question, can I predict the likelihood of infection? And, you know, with these 6 markers and looking at 1.2 million patient profiles within the NHS, we came up with a supervised learning algorithm. It's a machine learning technique that could predict the likelihood of infection to 83%. And what you can see from the ROC curves, that it's quite robust, even down to about 4 biomarkers. So with 4 biomarkers, we get about 80%, which was a really nice finding, because then that helps you then streamline that patient's care if he's likely to have an infection. And again, on the user interface, you know, it pops up here and tells you, for example, here, 85% likelihood of infection. So all these are tools which give information and which help basically the decision for which antibiotic to use. Now, switching gear and looking at diagnostic technology, coming back to the microchip I introduced, you know, we've all been there, you know, when we're working up with the flu and said, I need antibiotics. But we know, you know, if we had a technology, a simple technology which could tell us, is it a bacteria or a virus? If it is a bacteria, what strain of bacteria it is, so I know what antibiotics to use, it would be a game changer. And the vision is, you know, maybe it's something like this, you know, I don't know if you remember this, this was quite popular in my time, little Game Boy with a cartridge, Dr. Mario, you'd plug it in and you'd play with the antibiotics like Tetris. But wouldn't it be great if we had a handheld device like this, which you could give it a drop of blood and it tells you what your infection is? I'm hoping in the next 3 to 4 minutes I'll convince you this isn't really science fiction, it's actually closer to reality than you think. But obviously you need to serve some criteria, and as an engineer I love this. I mean, the World Health Organization has given me a spec sheet. They've said this is what we want you to achieve when you make a diagnostic. It's the asserted criteria. It needs to be cheap, obviously, less than £10 per test, obviously 95% sensitive and specific. Very, very user-friendly. I mean, I've learned a lot in my time as an engineer. You can make the world's best technology, but if nobody uses it, it's not going to have any impact. So we put a lot of focus on usability. It has to be quick, less than 2 hours, very robust, and equipment-free and deliverable to the users. And we can do that with microchips, because with the microchip that I showed you that's powering the phone, we take that same microchip, and within it, we embed 1 million chemical sensors with instrumentation, which can link to a mobile phone. And then on those chemical sensors, we can actually detect DNA and RNA, exactly the same methods as Jesus presented earlier, the molecular methods. And that's a great technology because it doesn't use any fluorescence, so you don't need any cameras or bulky optics. You can just use a tiny microchip, which is a silicon footprint of about 5 by 5 millimeters. Here's our flagship chip. We call it Titanics, primarily because it was made by my 2 PhD students, which were both called Nick. And as I said, it's a very small piece of silicon, 4 by 4 millimeters. This one contains 4,000 sensors. We take that, we put some microfluidics, and we put the molecular methods that Jesus is developing on top that identifies the pathogens. And that's our cartridge. We use novel isothermal molecular methods, which are quite convenient for us because unlike PCR, which needs to cycle in temperature, these just need a constant temperature. So thinking about a handheld device working with one temperature makes it incredibly simple. And it's extremely quick. You know, we can identify positives in less than 10 minutes. So here's an example of the Lacewing platform. You know, it's a handheld platform using custom electronics. We've got a disposable cartridge with the chip. Our chip price at the moment is £10 for basically looking at 12 pathogens per cartridge. You give the sample, and it gives you a result. But the other nice thing about this platform, the power of this platform, is that in real time, it also links to your mobile phone through Bluetooth. And then through the mobile phone, we go up to Google and the Amazons, the web services, and you can see what we've done here. We've got real-time surveillance and epidemiology. So at the moment that cartridge diagnoses something, it pings a point on a map. And that's very powerful because in terms of surveillance, you know, you can see outbreak prediction, you know, then it can start to give the epidemiologists data and tools in which they can then, you know, do policy and intervention to try and contain outbreaks. So it's an end-to-end solution from chip all the way through to the cloud. And it works, believe me when I say it. Obviously, you always compare against gold standard. Our gold standard is this big bench top £50,000 instrument called the qPCR. And here you can see real data. In about 7 minutes, we identified the antibacterial resistance gene. So it's a really, really nice application curves. So recently we published a paper where we also identified Klebsiella. And the other powerful thing about this technology versus, you know, your conventional rapid diagnostic tests is that it's also quantitative. So we can also tell you how many copies of that pathogen are within your sample. And it's got a very, very low limit of detection. You know, we're reliably detecting down to about 10 copies per reaction, so it's extremely powerful. To finish off, I mean, we're working with antimicrobial resistance, but there's other types of resistance as well. I just thought I'd bring this one up as well, because we're working in malaria as well, looking at artemisinin resistance in a similar fashion. You know, we can detect artemisinin resistance, and that's to help the anti-malarial provision of drugs. Again, very, very quick time, detection under 15 minutes, and it's quantitative as well, so it tells you how much the sample has in terms of copy number. And, you know, working on a number of projects. I mean, we've also been approached by Aspergillus because we know about azole resistance as well. It's quite important. And also looking at answering a simple question as well. Is it a bacterial or viral infection? Simple question, but which has massive impact. It's part of a global collaboration as well. I mean, we're looking at other tropical infections using the platform, and with Alison and Sophie and Kub, we're about to launch a program in Thailand as well, and in Vietnam. Working in Cape Town as well with tuberculosis, Ghana with malaria, and here in the UK in AMR. So lots going on, and I'm excited to announce for next year. So we started with this vision. and you know we're quite close. You know, the technology's there. We're looking to clinically deploy it in the next year, and also you know we've got a lovely slide here, a photo here of it being used at the Great Exhibition Imperial Festival, and it's been a great engagement tool. I mean, I like this photo because if a child can interact with it, you know that you're doing something right in terms of its usability, and the hope is that you know it will be used globally. So at that point, I'd like to thank you for listening to my talk. I'd like to thank all my great collaborators, Alison Holmes for inviting me here, all my collaborators in the decision support system, and my team at Imperial on infection technology. Thank you very much.